Okay, well, thank you very much for the kind invitation. The title of my talk is Evaluation of Drug-Eluting Technology for Below-the-Knee Interventions. I have no disclosures to make, so why drug-eluting technology for below-the-knee interventions? Well, frankly, because POBA and bare metal stents don't work very well below the knee. They're actually ineffective. If we look at this meta-analysis of us, 52 patients with over 6,700 patients published by Jihad Mustafa in Circulation and Cardiovascular Intervention, the technical success is actually very good. But at 1 year, there's a dramatic drop in primary patency. Repeat revascularization is almost 20%, and major amputation close to 15%. And likewise with primary stenting, in this meta-analysis published in the Journal of Vascular Surgery, we see that primary stenting with bare metal stents provide no benefit in terms of patency at 6 months. The debate BTK study, which was a single-center, non-blinded study of patients that were treated with a drug-coated balloon with a below-the-knee disease in patients with critical limb ischemia, this was a positive study. It showed that there was an improvement in terms of target lesion revascularization. But when we look at Impact Deep, which was a prospective randomized core lab adjudicated study of drug-coated balloon versus POBA in patients with infrapopliteal disease with critical limb ischemia, you see here that late luminal loss, binary restenosis, and occlusion rate was no better than POBA. There's many reasons for that, and I'm not going to go into them at this time. But interestingly enough, there was also an increase in a trend towards higher amputation in the drug-coated balloon arm. And this led for withdrawal of this device from the market due to global safety concerns. Interestingly enough, you see that the PTA arm of this study has significantly lower amputation than historical controls. Perhaps the question we should ask ourselves is, why did POBA do so well? Biolux P2 was another study similar to the previous one, but in longer lesions. And it showed the same. There was no benefit for drug-coated balloon in terms of target lesion revascularization or patency. So we have two strikes against drug-coated balloon. Perhaps the saving grace will be the Lutonix BTK trial. Jihad Mustafa had presented in Viva the safety data at 1 month. We're still waiting for the 12-month data. But if this fails, it's 3 strikes, you're out. This is a meta-analysis that confirmed what we had already learned, that drug-coated balloons confer no benefit in terms of target lesion revascularization, amputation, death, major adverse event, and a slight benefit in late luminal loss. However, there was no clinical benefit. So what about balloon expandable drug-eluting stents? They've been approved in Europe for a while for below-the-knee applications, and in the coronary literature, we know that there's a significant improvement in patency compared to non-coated or eluting stents. There's been several single-center studies that have shown that drug-eluting stents are at least safe and feasible in the treatment of below-the-knee disease in patients with critical limb ischemia. So predicating on this enthusiasm, 3 randomized trials were done in Europe comparing drug-eluting stent with POBA and bare metal stents, and all of them have shown that there was a benefit in terms of a primary patency at 12 months favoring drug-eluting stent. This meta-analysis will confirm the same findings, that drug-eluting stents are favorable in terms of a target lesion revascularization, restenosis, and amputation. The PATI trial is a similar one, with the difference that one of the inclusion criteria is that all the patients had to have critical limb ischemia, which were one of the criticisms of the prior studies. Now, in this study, there was a trend toward improved patency. 17 patients in the drug-eluting stent arm only got POBA, but if you look at per protocol analysis, there was significant improvement in patency. There was also improvement in major amputation, amputation-free survival, event-free survival, and even there was a cost-effectiveness benefit. Destiny 2 study was a similar one, but in longer lesions, almost 5-centimeter lesions. And you see that even though there was a slight drop in primary patency, it was still good, and a 12-month limb salvage was excellent. IDEAS is a single-centered study of a drug-eluting stent versus drug-coated balloons in very long lesions coming out of Greece. And it showed that even in very long lesions, there is a significant benefit in terms of patency. So in summary, PTA has poor outcomes with low patency and continued high amputation rates and dissections. Primary bare metal stent has similar outcomes, likewise with a drug-coated balloon. Drug-eluting stents are superior to PTA and provisional stenting with higher patency, less amputation, and less target lesion revascularization. They're also superior to primary BMS in reducing late luminal loss, target lesion revascularization, and restenosis, and superior to drug-coated balloons in terms of patency. The problem with DES is most infrapopliteal lesions are long and diffuse, and most of our data is in shorter lesions. We're still waiting for the data of Saval on long segment stenting below the knee. Thank you.